We're in a very exciting position at the moment because following the exciting data that came out from the Nelson study and previously the National Lung Screening Trial, we now know that lung cancer screening works and has a survival advantage. NHS England have now started targeted lung health checks. And as of today, I think there are about 43 schemes running across England in the first, second, and now third waves. As these are rolled out, it gives us a really good opportunity to begin to study biomarkers, because we can actually enroll people who are coming for the lung health checks into simple studies at the same time to collect biomarkers. So where are we with biomarkers? Biomarkers have been pretty challenging to do, and there are many groups looking at various things. For instance, various blood biomarkers such as circulating tumor DNA, proteomics, RNA, breath, etc. And there are a number of different biomarkers at various stages, phase 1, phase 2, phase 3 studies. But unfortunately, as we stand here today, none of them are being used clinically in lung cancer for diagnostic purposes. And that's what we've got to progress. So the opportunity is to, as I say, wrap these biomarker studies around the targeted lung health checks. So how might this work? There are 2 or 3 different things that biomarkers could do to help lung health checks. The first thing is that at the moment we use risk prediction models to try and identify those people at highest risk for lung cancer and enroll them into the programs. Could a biomarker or biomarkers actually enhance those risk prediction models and be used in conjunction with them? This might in fact better identify who to screen, which, as you can imagine, could have cost effectiveness benefits, because you don't have to screen people who are at lower risk. That's one opportunity. Another opportunity is to help identify the nature of indeterminate pulmonary nodules. So quite often when scans are done, we see these indeterminate pulmonary nodules. We're not sure what they are. We end up surveilling people over time. So you have the baseline CT and then a 3-month scan and then another scan 9 months after that, so a year from baseline, following these nodules. But actually, if you had a biomarker that could confidently say this is not a lung cancer, then it might speed up the process for the individual and reduce the number of scans and of course make everything cheaper. So there are various ways that biomarkers could be used around lung health checks. A note of caution is that although, as I said, there's lots of work going on in biomarkers, one of the issues is sometimes people do work in one area and then try and apply that biomarker to a different area. For instance, if you have a biomarker that's good for advanced stage disease, say something the size of my fist in the left lung, that's great, but will that same biomarker work in a screening setting? So rather than a patient coming in symptomatic with a large mass, with a positive biomarker, they then take that biomarker and say, okay, can we now use it in a screening population, looking for much smaller tumours, things the size of my little fingernail, where in fact, of course, it may not work. So the important thing is to, with biomarker research, is to identify the population you're interested in and study that population from the get-go. And as I said, the lung health checks allow that. So what's being tried? What's being done? There are various initiatives currently in progress. There's quite a lot of work around looking at proteomics, protein-based biomarkers, and some of those have been quite promising. There's some quite exciting work showing that actually a panel of a small number of protein biomarkers in the blood, when added to a risk stratification profile, actually improves the sensitivity for detection of cancer. So that's exciting. There's work going on in circulating tumor DNA. ctDNA, as it's called, the studies have shown that you can get good detection in advanced stage disease, stage 4 and stage 3 disease, but as you come down to smaller tumours, stage 2 and particularly stage 1, the sensitivity does drop off. So we're down to about 21-22% in stage 1 disease, which of course is really frustrating because they're exactly the tumours that we want to identify. maybe I should have said that in a screening program, around about 70% of the cancers identified, 70 to 80% of the cancers identified are actually small stage 1 and stage 2 tumours, which is of course exactly what we want, because then we can operate on them or give them radiotherapy and cure people, but it makes biomarker work more challenging. There's work going on in breath as well, breath analysis, and I should declare that I work with a company called Alstone Medical who are developing breath biomarkers, and that's again an exciting opportunity. I don't think it's quite ready for the screening setting yet, but there's lots of work being done in that area. There's also work being done on autoantibodies, and one of the initiatives that I'll mention is a study being run by Peter Johnson from out of Southampton called the IDX study. And what they're doing is they're working with several of the lung health check programs, and they are collecting samples at the time that patients come in, or people come in. And they are looking at a proteomic panel, a circulating tumor DNA panel. They're looking at also antibody panel as well. And they hope that those biomarkers, either singly or in combination, may enhance screening. They've now recruited nearly 7,000 patients for that study, and we'll begin to get some readouts, and I think there's work here at BTOG, posters being presented on that. Another area is AI, and there's work being done out of Oxford by Fergus Gleeson around AI, and it's something called the DART study. And the DART study is looking at lung nodules, and they're looking at the radiomics of the nodule, a sort of deep dive analysis into the radiomics of the nodule combined with clinical data and biomarkers and pathology, and trying to combine it all together. Again, to say, can AI help identify these nodules and determine whether they're benign or malignant, etc. And linked into that, there's a study called SCOOT, which is collecting biomarkers as well. So there are a number of initiatives going on. I know there are 2 or 3 other studies around the country, again working with lung health checks in a smaller way, collecting various biomarkers. So there's a lot of activity in this area, and I think we'll start to get lots of readouts over the next few years. So I think just in conclusion, lung health checks, a national screening program is coming. The National Screening Committee have made a recommendation that the government implement a lung cancer screening program, and that's currently sitting on ministers' desks in a consultation exercise, and we hope to hear very soon an approval for that. Once a national screening program starts to get rolled out, again, it gives us the opportunity to wrap these biomarker studies around. So I think this is not going away. It's going to get bigger and better, and hopefully in the years to come we will identify biomarkers that can help identify lung cancers at an earlier stage, make the whole process more cost effective and easier for patients.